This video is part 2 in our educational series on how to utilize a conservative treatment approach by treating soft tissue restrictions for a client who has degenerative disc disease of the cervical spine. In this video, I will cover the following: clinical signs and symptom presentations in a degenerative disc presentation, understanding the role of referred pain and interpreting the symptom patterns, and functional-based testing to determine if a degenerative disc injury is present. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a soft tissue injury treatment expert specifically for chronic neck, shoulder, and arm pain. My focus is on finding and fixing nerves that get stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain without the use of drugs, injections, or surgeries. This leads to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I am also the creator of the PEAK method, where we teach overworked manual therapists a new injury treatment system that eliminates the frustrations of not getting consistent results, allowing them to reduce their treatment times by at least 50% and easily double their income. All right, let's get into the video. This is part 2. If you haven't watched part 1 in the series or any of the other videos in the series, if you're watching on YouTube, I'll link it up top. If you're watching this anywhere else, it'll be down in the description box below. But now I want to get into clinical signs and symptom presentations in a cervical disc injury. First is going to be age. Now, usually I tend to see more disc degeneration presentation, specifically like bulges and herniations and protrusions and extrusions in an older population. But that isn't the case nowadays. I'm starting to see this more and more in a younger population as well. I really believe this is just from being more sedentary in our postures and what we do. You go around and look at like teenagers and people in their 20s, they're just like glued to their phone looking down all day long. So I'm seeing disc presentations a lot earlier than I used to in practice. I'm going on 15 years in practice, but I'm seeing it a lot earlier than I used to. So it is definitely more common in a younger population as well. And a lot of times it just gets missed by most providers because, someone might get like an MRI done and there might be some bulging or even a herniation, and the radiologists and the doctors kind of downplay it. They're like, well, they're only in their 20s or 30s, so it doesn't matter. But if the client is coming in and they're in severe pain and they're having issues, the disc does matter. Symptom location is always going to be pretty key for me. Definitely going to have a lot of neck issues. I tend to also see a lot in like the posterior part of the back, like basically into like the shoulder blade down to the rhomboids into the trap as well. That's a very common area for disc injuries and disc referrals for sure. Quality of a disc problem is going to be pretty intense. It's going to be, I always say it's like sharp. Sometimes it's stabbing, it's shooting, maybe throbbing. When I'm taking a history and I ask all the questions, I'm like, hey, what does that pain feel like? And you're going to see that a lot with a disc injury, like that shooting, throbbing, stabbing type of pain, knife-like as well. And a lot of people will like feel it in their mid-back up in the traps as well. Severity is really key too. So when I ask severity of a client and I say, hey, on a scale of 0 to 10, 0, no pain, 10, you wouldn't even care if I cut it off. What is the worst that pain is? And really, when it's like a disc and it's really flared up, sometimes they can have episodes of like a 8 or a 9 out of 10, where it might be really intense for a little while. That might be when they have one of those internal disc derangements, or maybe they rip the disc for the first time, but they tend to be a lot more intense in severity, and the symptoms are just a little more, I guess, violent and a little more aggressive. Definitely see things like what makes it worse. And a lot of times disc injuries tend to be a lot worse, maybe with like positional stuff, or like, oh, I'm on the computer all day, or I'm sitting too long. That tends to make it worse. Usually what makes disc injuries feel a little bit better is if they get up and move around, maybe they do some breathing, maybe they lay down. So I always want to see that there's something that makes it worse, something that makes it better. Definitely time of day symptoms, they tend to be a little bit worse at different times. So a lot of times when I'm seeing more of like a degenerative component in the disc, they tend to feel a little more lousy when they first get up. And then it feels a little better as the day goes on. But then by the end of the day, they're really banged up and beat up again. I tend to kind of see, I call them like temporal factors in the disc injury. Next is, was there direct accidents or injuries to the neck itself? A lot of times if there was, that's going to also point me more in a direction of like, hey, there's some degenerative components in here. I have to think about this. It's not just the soft tissue. Also, I want to know like what are they doing for recreation and activities? Are they like going to the gym and just beating the ever living hell out of their body? Are they doing like crazy yoga poses and they're like in all these weird handstand positions? Are they doing some type of like, I don't know, sports where they're like colliding with people? I need to know that and really know what they're doing. And then I really also want to know if they've played any collision sports. So myself, I played football through high school and college. My neck's all blown up. I got disc injuries left and right. I remember when I got an MRI, the radiologist called me and asked me how many car accidents I've been in. And I said, none. He goes, oh, well, it looks like you've been in like 12. So collision sports can definitely be a big factor in there as well. And then lastly, just what is their job? Are they stuck at a computer for, 26 hours out of 24 hours a day? Are they stuck not being able to move? Or maybe they're like a manual laborer and they're in like a weird position, like an electrician, and they're like looking up, or a carpenter or something like that. All these factors are really important. We don't want to just like look for like one thing. We want to look at it as a whole and really get an idea of what is going on. Now, this one is really important. I call them referral patterns, but they're also known as sclerotomes. So basically, in the neck itself, you have different levels of your spinal cord that kind of control different areas. And a lot of times, when people get some of that like deep, throbbing, aching pain, a lot of times it's actually a referral from one of the cervical discs in here as well. And you can see they can go in all different places depending on where it is. So what do they tell us? They tell us that there's some type of inflammation and damage to the joint itself where it doesn't really make sense. The client will be like, oh, I got like this deep pain in my, trap through my rhomboid. It must be that problem. It's not. A lot of times it's that referral. And if you took that proper history and really got a better idea of what's going on, you'd be looking for this as well. They're definitely not a trigger point. So many people out there say they treat trigger points. And a lot of times I'm seeing trigger points form in muscles in response to something bigger going on underneath. A lot of times it's like an entrapment of a nerve or the disc itself. And a lot of times the trigger points are forming as like a protective way to go in there and take some pressure off of that area and kind of buffer it. And then if you're going in and just releasing the trigger points, it temporarily feels better, but it actually exposes that joint and that disc even more, and they might have a bigger problem. So if you got a client that comes in, you just do trigger point work, and then they go and feel better, and then they're like, oh, I'm going to go to the gym today. Then they're just going to load that disc even more because you're really only treating the effect, not the cause. Next is they're definitely not a rib out of place. This is one of the favorite things that chiropractors do. I have a degree in chiropractic. I don't do any adjustments, but basically when people come in and they're having like that deep, feel like it's hard to breathe, that stabbing pain, they tell the chiropractor, say, oh, your rib's out of place. We just need to pop it back in. And they do an adjustment. And when they do an adjustment, what it does is it creates like a temporary effect in the spinal cord and blocks some of that pain, but the rib wasn't actually out of place. If your rib was actually out of place, that's like an emergency and you need to go to the hospital. It's not like this one little vertebrae slipped out of a rib and it's giving all this sharp stabbing pain. It's really coming from the neck as well. So it's not a rib out of place. And with sclerotomes, as I said earlier with the disc, they're usually worse in the AM. They're better with movement throughout the day, and then they're worse again at the end of the day. So you really don't want to get stuck just going symptom chasing. If a client comes in, they're like, have pain in these areas, you think, oh, it's just a rhomboid problem. It's just a trap problem. More than likely, especially if it's chronic and you took a thorough history, it's going to be more of a problem with the disc and the disc getting inflamed. So you need to treat around where the disc is, not where the pain is going. So referred pain tells me it's a problem, but I also don't want to get stuck kind of chasing it and only trying to put out the symptoms and not getting to the root cause of what's going on. Next is just going to be functional based testing. So we took a thorough, when I'm looking at a client and I'm doing a history, we take a thorough and detailed history, and then we kind of get an idea of like what potentially could be going on. I always say there's 7 problems that could cause issues. It could be a bone problem, cartilage problem, disc problem, ligament problem, nerve problem, soft tissue problem, or tendon problem. So based off of that, we're going to be able to really understand what's going on. We need real data. So many people just go off of the symptoms. They're like, oh yeah, just jump on the treatment table. Let's see what happens. And you really don't have a clue as what's going on. You're just kind of stuck, winging it and being like, oh, I'm going to try something new. Maybe today I'll stretch it. Maybe I'll jam my elbow in there. Maybe I'll do some cupping. And you really don't have an idea of what's going on because you can't fix a problem if you don't know what it is in the first place. And it's important to get both subjective, which is like symptoms and how the client feels, but also objective data, which are things that we can actually measure, like tests, movements, videos, photos, and things like that. I do a lot of that in my practice because it really helps the client see the data as well. Because the client's going to be really focused on the symptom side of things, and they're not going to focus as much on like how things are functioning. And my rule, I always say, in order for it to improve, we must get it to move better as well. So I always start off by taking a photo. I want to have a baseline of where I'm at. It gives me an idea where I am. So I always take a photo as I'm going in there and doing it. It gives me a better idea. Then I ask some questions. So now this is where I'll get some of that subjective data. I say, do you feel any pain or discomfort anywhere? I'm always getting, every time I'm doing a test, I'm doing that. I'm getting a photo first. Then I'm going to get, do you feel pain or discomfort anywhere? Then I ask, how would you describe the pain? I want the quality of that. That's another subjective finding to give me an idea where I'm at. Then lastly, how intense is the pain? That's when I go 0, no pain, 10, the worst you've ever had. So this really gives me an idea of like, am I dealing with more of like a soft tissue component, or am I dealing with more of like a disc related component? A lot of times if it's like that sharp stabbing pain, it goes in a certain area where it radiates and it's like 7 or 8. I'm thinking more of the disc and less of the soft tissue generating that pain. I'm still going to get in there and treat the soft tissue, but I need to know where that disc is bad so I can really get my treatment focused in the right area. What I want to include next is it's just gonna be a clip from our advanced training course on neck and shoulder. I'm going to link in here a video of me going through what I call the disc functional test, and you're going to see what I do, how I do it, how it breaks down. So I'm going to link that up right now. So we're going to do our cervical functional test. The first one is going to be the cervical functional test to see if there's a disc injury. So with this one, we wear the glasses because they're going to help us give some baseline and some measurements for that. And you're going to have the client right up against the wall. And what you want to do is have their heels against the wall, their butt against the wall, and in through that. And their head is going to be up just like this. So the first test we're going to do is we're going to see how these upper cervical muscles are functioning. And we're also going to see if there's a disc injury in there as well. So what we do is we tuck their chin back. And this is going to be a weird motion for the client, so you got to take them through a few times. And what you're going to tell them is we're going to be sliding your head up the wall and tucking your chin. So we're going to tuck the chin and slide the head up the wall. It's a little bit of a strange motion, so you got to kind of coach them through that. I'll give a couple cues of like tuck your chin and slide your head. Good. So then we're going to do that test, and this is going to be one where we're going to get in there and ask them what they feel. So come out of that test, you're always going to ask them, where do you feel the pain? What does that pain feel like? And how intense that is. And a lot of times when the disc is very inflamed and is causing problems, they're going to get a lot of dysfunction back through here, some pain down into the shoulder blade, down into the arms, and they just will like almost have this face of like impending doom where it's very uncomfortable. And when you see that, it's going to let you know that there are some disc injuries in there, and you're going to have to go first and decompress that disc and unload that. So what I always want you to do on this first test is once you get that, you're going to come in and you see that, you're going to take a video of them doing that a few times, because it's going to be really good data to show the client before and after as that gets better. So on this first test, if you're just checking for the disc, I want you to take a video. Just a couple of take homes from the video and what you do. You know, you're slow, you're deliberate, you're collecting data. You know, so many of us as providers, and I made this mistake for years, is I just wanted to jump right into treatment. And then I'm kind of stuck doing a bunch of stuff and never really know what works. This allows you to line it up, get it perfect, and know exactly where to go so you can get those long lasting results and get real results and have a plan as to what is going on. So all I got for this video, like I said, if you haven't watched any of the other ones, the links are included everywhere. This is going to be about a 5 or 6 part series because it's such a in-depth, important thing, and what you'll see in clinical practice as well. If you like the video, you know, share any insights you might have gotten in the comment section below. I try my best to respond to everyone and share information across the board. I'm really just here to help share with others and learn from others as well. You can also do me a solid and share it with other providers that you know it might help. And lastly, go download our free training modules. The links to that are wherever you're consuming this. We do have our full neck and shoulder online course available from start to finish, where we go through all that. If you want to jump ahead and go see all that, go download it. No strings attached. It's there. Put it out there, because I'm tired of, you know, all these so-called gurus and nonsense people out there pretending like they got this magic thing. I'm going to show you how to do it all. The goal with that is like, hey, you like it, you come in, you learn from me in person and really get good at that. If not, you're still at least going to start thinking critically and changing the perspective of how you approach treatment. I appreciate you watching the video, and I'll see you on the next one. Bye.